Purple rain, purple rain, purple rain. That's how I'm feeling today. But hey, man, welcome back. Big Money Bound TV, RRT Posse. You already know what's going on. Nothing but respiratory related materials going on here for you. And today what I'm going to break down for you is being an ICU therapist. An ICU therapist for that night. Let's say you're an ICU therapist for that day or for that night. This is the things that you're going to encounter, what you can expect, and what you should do. So first things first, you want to arrive to work on time. That's kind of difficult for me, even though I live right down the street from my job. I got a problem with getting there on time. It's been like that for years. But for these last for the last 2 months, I've been on time because at my per diem job, they take that stuff serious. They had pulled me to the office like, hey man, you got to sign this verbal warning saying that you've been late more than 6 times this year. And it's a revolving calendar, so I haven't been late at none of my jobs for the last 2 months, so I need a pat on the back. Y'all should applaud me in my comments. All right, so once you get clocked in, you get yourself situated, you get your stethoscope, you get your pulse oximeter. Now you're ready to gather a report. The report should be taken in the unit at the patient's bedside. Every patient that's respiratory has a respiratory issue gonna be receiving any kind of respiratory treatment or that's on 100% oxygen. You want to get a report on that patient at the bedside. That's what I recommend, because you get reports somewhere else. Someone tell you what's the vent settings for the patient. You go into the room, the vent settings are completely different. Now you don't know if they changed them and forgot to tell you, or if the doctor came in here and changed them. That's why you want to get a report at the bedside, man. You want to make sure all the settings are the same from what the therapist is giving you. So you want to make sure all the settings are the same. Okay, they tell you 100% oxygen, tidal volume of 500, rate of 16. You see it's a rate of 18 now. Like, hey, I see your cells told me a rate of 16. Now it's rated, but you have a rate of 18 on the vent. What's going on with this? Oh yeah, I forgot to change it. What happened was the patient's CO2 was very acidotic, so we had to blow off more CO2. So I increased the respiratory rate. Cool. That's important things to know, because if somebody tells you that outside of the unit, you write everything down outside of you write everything down at the nurse's station desk in the unit. They saying it's a rate of 16. They got 18 inside of the room because the CO2 was high. You go and turn the patient back down to 16. The CO2 gonna build right back up. So you got to make sure you take this stuff like real serious and be like dot your I's and cross your T's when it comes to like those vented patients, especially those unit patients. And then you want to know what size tube it is, and where is it at on the centimeter? What's the centimeter mark on the tube? Like, is it at 22 centimeters, 24 centimeters? Because you come in there, somebody say, okay, the tube is at 22 centimeters. You come in there, it's at 18. Whoa, what's going on here? All this stuff, I can't stress it enough, man. Make sure, it's all about covering yourself. Make sure you cover yourself. Hey man, you saying it's at 22? I'm saying 18. What's going on? Oh well, when we intubated, we had it was a right main. It was in a right main stem, so I had to pull back some centimeters per the doctor's orders. All right, I'm telling you, be on top of your game when it comes to that bedside reporting. So you're gonna get a report for every patient at the bedside that has any kind of respiratory therapy for that night, any kind of respiratory issues, any kind of respiratory treatment that they're receiving for that night or day. I'm saying night because I work night shift. So once you get the vent settings, what they came in for, what's their history, how many days they've been on the vent, why did they fail their weaning trial throughout the daytime if they had one. That's all important, because you want to be able to get this stuff to the therapist that's coming on the next shift in the morning, so when they try to do the weaning trial, they see if the same thing takes place. Now you can say, okay, we switched the patient over to CPAP, 5/5. He failed the weaning trial because the respiratory rate was too high or was too low. You want to give them a reason why, what's going on. It could have been too high. Dude could have been nervous and crazy, scared. He don't know what's going on. I just had full ventilator support now it's all me, it's no help. He breathing 40, 45. So the next time you want to tell the day therapist, hey, before you do it, just let him know what you're going to do. Explain it to him. He has to breathe on his own, take nice deep breaths, nice and calm. They probably didn't do that on the shift before. So it's these little things that go a long way, that make a big difference. So once you get all your reporting, all that information taking place, a good thing, once you start your first initial assessment of the patient, now you're doing your assessment and your event checks, a good thing that you want to do is, wherever the ET tube is, slide it to the opposite direction. If it's on the left side, it's been on the left all day, slide it to the right so the patient's lip doesn't start to break down. That's a very important thing. I know you probably see, well, you shouldn't see it, but sometimes you come in a patient room and probably they have like a little, could be like a little blister under their lip. It could be because the tube has been sitting on that one side. It couldn't be, but it also could be the reason why. So just make sure you slide it over every day, every shift, just to make sure you have no skin breaking down. So in your initial assessment, you want to listen to your breath sounds. And if you hear clear breath sounds, if the breath sounds is clear, you don't have no peak pressure alarms going off, you got a normal peak pressure reading, there's no need to try to suction the patient if the breath sounds are clear and there's no peak pressure. That's my opinion. I'm not saying this is right. I ain't saying this is wrong. I seen, like, in your Egan's book, or maybe it was just in my respiratory care program, they say you don't suction like once every hour or once every 2 hours. You suction as needed. If it's not needed, don't give it. If suction isn't needed, don't do it. You just sticking something down somebody's throat and pulling it out and just, come on, you're irritating that way already. So if it's not needed, don't do it. So it's not scheduled suction. It's as needed. So when you're doing your first initial assessment, you want to get breath sounds, get your SpO2 reading, your heart rates. You really want to go check all your alarms, check the position of the tube. You really want to be very fine. You want to skim through everything with a very fine tooth comb to make sure everything is good, everything is right with that patient, so you know where your baseline is when you first came to that patient. So once you do your first initial vent checks and your whole assessment of all the patients ventilated and everybody receiving respiratory care, you got to give your breathing treatments. You want to do that in a timely fashion. When it comes to the unit, you want to really balance, like you got to really, it's a balancing beam. You got to balance your priorities. Patients got treatments, patients on vents. Which one you think come first? These ventilated patients would come first. So you want to take care of that before you take care of your treatments. And you want to do both of them in a timely fashion so everything is like up to date, everything is on time, nothing is late. Now throughout that day, throughout that night shift, you're probably going to have, you may start off your night with like 3 vents. You may end your night with 6 vents. People coming in through the ER, being intubated, coming on up on ventilators. So you got to make time to be able to deal with that. So that's why you got to really stay on your P's and Q's if you're in these units, man. Then you got to also worry about the nurses calling you. Hey, I got a patient over here. There's something's going on with this patient. You got to worry about the miscellaneous things. Hey, I got a patient over here. My sats are dropping. He's coughing up a lot. That's the biggest one. My patient is coughing. Can he have a treatment? You want a treatment because the patient is coughing? Like, coughing is, that's good. That's normal. Coughing is normal. I was just coughing. I don't need a treatment. Or he's just coughing, so he need, no. If he's coughing, let's get him some cough syrup. Let's get him a cough drop. If he's coughing, hey, that's the biggest thing, man. My patient is coughing. Can he have a breathing treatment? I understand respiratory therapists, airway treatments, but come on, come on now, man. That's why I may be some beef between nurses and respiratory therapists. That's gonna be my next video, man. I ain't gonna say that. I can't say that's gonna be my next, because people have been holding me to all this stuff. People still saying, we want to see that respiratory therapist check. So I ain't gonna say that's gonna be my next video, but I'm gonna do that. I'm gonna upload that video soon. Is that beef between nurses and respiratory therapists? But yeah, if a patient is coughing, I always say, hey man, let's get him some cough syrup. What's the saturations? 100%. Come on, man. But I always go in there, look at the patient, listen to the breath sound, say everything is good. He probably don't need a treatment, probably just had a little coughing spell. He good now. So you got to deal with those miscellaneous phone calls. Then you got to keep in mind that you still got breathing treatments, most likely Q6 or Q4, so you got to keep doing those throughout the night. Then around 5 o'clock in the morning, they ordered ABGs for all ventilated patients to see how the patient has done throughout the night on the ventilator, see if there's any major changes in the values. So you got to worry about doing all those ABGs. So you really got to be focused on your time management to get all of this stuff done. It sounds like a lot, but once you learn like your process, it can be very, very easy. Speaking of processes, when it comes to it, here's my process. I get bedside report. First, I walk into the unit. I look at everybody that's on the ventilator, see how many vents I got, see if I can see how critical the patient is. Are they on like, sometimes they're on certain kind of motor beds that's very critical situation, like it's a lot going on with this patient. So I go and see how critical all my patients are, look at everybody that's on the vent, talk to the nurses, see how the patient was doing that day, make sure everything was good with them. Then I get bedside report on every patient that's on the vent. Then I go and assess every patient that's on the vent, do a thorough vent check, current values, alarms, set my alarms to a tight parameter so I know when anything goes wrong. Get all of my regular SpO2 volumes, my heart rate, and my pulse ox readings. Then I give all my breathing treatments. By that time, if I do all that in a timely fashion, I got a window. See, I don't want to say how big my window is. I know, like, I got, feel me, my coworkers may be watching this, or my administrator may be watching this at my hospital, so I can't let them know. But you got a window between 30 minutes, probably an hour and a half, 30 minutes, hour and a half of downtime. So, in between that downtime, you can getting yourself ready for the next round, grabbing your meds for the next round. But me, I'm normally just in the unit, kicking back. I'm there if they need me. Next round, that's the 12 o'clock round. Do all my vent checks, give all my treatments, and charge for all the ventilators. Do all of that. That should be a little bit more quicker than my first assessment because I did a very thorough assessment the first time, and I don't have to do as many checks the second time that I did the first time. So that should be a little bit more quicker. So now I got a little more downtime from an hour to an hour and a half to 2 hours. Hey, I got this stuff down pat. Then I got my third round. That's my vent checks. That's my treatments. That's my ABGs. Now I'm getting ready to, after all that, I should be done with all that in a timely fashion. I should be done with like at least 35 minutes to spare to look up any new information on the patients that came in before the patients were here that I got here, patients I had before I got here. So any new patients that's come in, I got time to get report on those patients, look up all the information on those patients. So when I'm giving reports to the next therapist, I got all the information that therapist is gonna need. So once I get that, I'm in the unit now. I'm waiting for the next therapist to come on. He or she comes on, I get them report. Now what I'm doing, I'm skipping and whistling out of the unit, going to my department, not saying nothing to nobody. Hey, don't mess with me, don't mess with me. Hey, especially if you ain't come help me, don't mess with me. Going to my locker, getting my keys, kissing my keys. Respiratory therapy got me here, and I'm getting ready to leave, man. Then I tell everybody, you know, good night, good morning. I hope y'all had a great night, man. I like to tell all the morning therapists, people that's coming on, hey, good luck, man. You gonna need it, man. Good luck, dog. It's rough out there, man. You gonna need that. So yeah, and that's basically what it's like working in ICU as a respiratory therapist. All right, so something I gotta say to y'all. I'm currently in a situation where I've been a therapist, man, for 3.5 years, and I've been really like stacking this steady, getting to this dough. So I'm finna purchase a home. I'm purchasing a home. I got like 2 more weeks and it's all official. So I'm finna move out of the spot that I'm in now, and I'm finna move into that new house. Brand spanking new, freshly built, upstairs, downstairs, 2-car garage. Man, respiratory therapy been good to me. So do y'all wanna see that transition of me moving out of my house, me moving out of the apartment I'm renting now and moving into my new house? Like the whole empty house tour, then I'm moving into my new house, a new empty house tour, then a future furnished house tour. Do y'all want to see all that? Because if so, just leave a comment, let me know, say yeah, you want to see more, and I'll be sure to add that on to my channel, because I'm moving from here, I'm going over there. Hey man, respiratory therapy, man, I ain't got no complaints, man. Big money bound TV, that's all I'm gonna say.